And role of M mode in cardiac arrhythmias in the fetus. I do understand that M mode is thought to be a very challenging and a difficult thing to acquire, but it is actually not. Because you're not guys used to it, that's why you feel it little uncomfortable using an M mode. M mode is a wonderful technique, and let me actually take the scare out of you by sharing this in video how to take an M mode. But let's start from the basics, and basics are that in a normal heart, the P wave, there is a normal sinus rhythm, and in the normal sinus rhythm, the impulse starts from the sinus node, spreads to the both atria through a specialized tissue, and then through the AV node into the ventricle, and there is a deliberate delay created in the AV node so that the atria and ventricle can contract sequentially rather than together. And this is the ladder diagram, which would be very useful once you are trying to figure out atrial and ventricular contraction in an M mode, and I would share with you there when I show you the cases. Now this is the origin of the impulse, and then there is an atrial spread, and there is the delay in the AV node as a red bar, and then there is a ventricular contraction. So you have a P wave representing atrial contraction and a QRS followed by the ventricular contraction. We in the fetus we don't have availability of an ECG, so we have to depend upon its mechanical correlates, what ECG correlates with the mechanical events in the heart. For example, the E wave actually represents ventricular diastole, and the P wave or of the ECG actually is shown by the atrial contraction or an A wave in LV or RV inflow signals, while the QRS complex leads to ventricular contraction, and then the mechanical correlate of ventricular contractions are many. One of those is an flow in the left ventricular outflow or flow in the right ventricular outflow. So when you see the outflow, which is represented by V, this indicates ventricular activity, and the A wave in the LV inflow indicates the atrial activity. Same on the M mode, the atrial activity is seen this like a downward movement here, and ventricular activity is seen like that. So if this is an M mode representation of the mechanical, so A is atrial contraction, and ventricular contraction on an M mode is represented by V. Let me tell you, M mode is actually the best out of all. Once you're talking of assessment of arrhythmia, it's the M mode which clicks in the most of the, except for a very few situations like what? Like mechanical PR interval, where M mode obviously is not good. Sometimes it's shared better in ventricular atrial ectopics, but I would still tell you M mode would bring out almost all cardiac arrhythmias far more nicely than a Doppler. So if M mode is so important, let's spend some time. Let's make the things look very easy, and it is easy once you understand it. What do we need for arrhythmia analysis? We need two things. We need atrial contraction and we need ventricular contraction. Agreed? So how do we get an atrial contraction? We put an M mode cursor which passes through the atrium, one atrium or one ventricle. Once it passes through one atrium and one ventricle, you would get an atrial and a ventricular contraction simultaneously. So this M mode cursor, preferably M mode cursor should be at the place where the nice atrial contraction. Ventricular contractions are usually strong. Wherever you put the cursor, you'll get something. But atrial contraction visibility depends upon the place where we put the cursor. So choose the place, like in this case, this is the nice place where the atrium is contracting and you are likely to get better, and this is not the place where atrium is contracting so nicely. You can see the difference between the two. So likely that you put a cursor here, you'll get a very nice atrial contraction. And how do you first, something important that you must optimize M mode. If you don't optimize M mode, you won't be able to see the atrial and ventricular waves very nicely. What are the methods of making an optimization? But before that, I'm going to tell you what the M mode is. Let me go back to the basics only, don't worry. So if in the basics, if you see what is an M mode actually, M mode is a very thin scan line. Okay, let's say if this is the heart and this is the pointer, this is the cursor of an M mode, and if we put the cursor here, now this is the small thin line it would scan. Now this line here represents the structure in front of the right ventricle, and this is the right ventricle cavity lucent. Then we have an interventricular septum. Then we have the ventricle cavity, which is absolutely translucent, and then we have a posterior wall. So now if we play this small cursors, small scan lines with the time on a chart, that's what is an M mode. Now if I place all small scan lines on a time scale, then I would get this kind of a chart. So now in this phase the ventricle is moving down, is contracting, and interventricular septum is thickening also. The posterior wall is moving forward and is thickening also. So now this would give me a nice chart of small scan line, and these lines I have drawn for you just to show that this is the right ventricle, this is the right ventricle, this is the right ventricle wall, the right ventricle wall in the IVS and IVS here, and LV cavity is here, the posterior wall is here. Mentally you don't have to draw a line, you have a scale on the side and you can correlate with that. But remember, when you have a 2D and M mode side by side, you can very easily correlate the structures what you see on a 2D and M mode. So that was the beginning of understanding of what the M mode is. Now once you want to optimize the M mode, occasionally you may not be able to get an atria and a ventricle contraction. So if you are unable to get an atrial and ventricle contraction, you use another surrogate. What do you use? For example, in this cursor is passing through the RV, and it's passing through the aorta, the aortic valve, and left atrium. LV, left atrium, and aorta. Agreed? So now if this cursor is passing through this, lower down you see this is opening of a aortic valve, and this is the atrial contraction. So this is an atrial contraction, and that is opening of the aortic valves. Opening of aortic valve means ventricle systole. Exactly. So we have an event of ventricle systole and an event of atrial contraction. This is what we were looking for. So many a time you can use this also innovation once you're doing an M mode. You must zoom it, because if in the unzoomed view, in this case you are unable to see the ventricular contractions. You do not see the aortic valve opening very well in the unzoomed view, and you don't see the good atrial contraction. So zooming is very critical for the M mode assessment. Speed, again, it depends upon what kind of arrhythmia you want to see. Many a time if you are looking at a very fast moving arrhythmia, then you have to keep the speed high, and in case the arrhythmia happens very occasionally, then you keep the speed low so that you pick up the arrhythmia. So speed is a kind of a relative thing you can decide as when you see one arrhythmia. We now have a new tool. For example, let me share one concept with you. Let's say I am scanning a fetus. Now during the scanning the fetus, I see some ectopic, some missed, some arrhythmia. Okay, then I put my M mode later on and continue to wait, and then that arrhythmia may not happen for next half an hour, 1 hour, or 1 day. You missed the boat. You saw it on a 2D, you were not on M mode that time, and on 2D it's very difficult to make any assessment, then what do? One trick: whenever you see arrhythmia, you press freeze. Okay, you freeze the machine there. So once you've frozen, what the machine does, it saves the loop prior to when you've frozen that image. It may be 10 seconds, it may be 15 seconds, depending upon the setting you've made. So once, if you are using a GE machine, then what you can do is that you freeze at that moment and then press P2. So pressing P2 after freeze would save a loop which retrospectively of 30 seconds or 15 seconds, which you can change in your settings. So now once you saved that, now you can apply M mode on the saved 2D clip, which is wonderful. So now I have saved one clip on this side and I am applying an M mode on a saved clip. Okay, now see this. So this was the saved clip. We put an anatomical M mode. Now another beauty where is that this is the usual cursor of an M mode, which is supposed to be there from the machine, but you can rotate this and you can have an angulated M mode. We call it an anatomical M mode. So we've done an anatomical M mode on a frozen 2D clip or 2D clip taken retrospectively. So the moment you get arrhythmia, you just freeze, press P2, go to that saved clip, and on the saved clip, the M mode, you press on M mode on the saved clip and you would have these kind of things. Okay. Now in this you see the atria contraction. Now I have kept the speed very slow here, and this is the patient of complete heart block. You see the atrial contractions, and here you see the ventricular contractions, because I have made this anatomical M mode pass through the one atrium and one ventricle, and this ventricle is now showing a ventricular ectopic. So we can see a rare phenomena which is ventricular ectopic by using this anatomical M mode. A step further, again, if you have a patient where you saw the arrhythmia and then what you do, you press freeze. Once you press freeze, you save it by P2, you saved, then you open by clicking that 2D clip, and once you open that, on your console you will see M mode button enabled. It would be, light would be on, rest all the button would be disabled, right? So you press on that M mode, and once you press on the M mode, there is an option of a dual M mode. On the screen you would see two up and down screens. For once you select, maybe I would show you a small video later how do you see it on the machine. So for anatomical M mode, maybe I'll take another small video. Now this is an anatomical M mode. We can have two M modes. One M mode, the green one, is this, passing through two ventricles. We don't have to pass through one atrium and one ventricle, because many a time you don't get a good image. So you have one passing through one atrium and one passing through one atrium, one passing through ventricle. So atria and ventricle. So you can actually slide up and down to get the best pick. So this one is an atrial contraction, this is the ventricle contraction, and you can correlate these two for assessment of arrhythmias. So this is how it's done. Just now we've selected one M mode, we make an adjustment in the gain settings, and then we can rotate this cursor and take to the appropriate place where you get a good ventricular contraction. Now the second M mode cursor, now second M mode cursor you take to a place, you rotate so that you get a good atrial contraction. So these are fortunately simultaneous, and you can correlate arrhythmia with this. So one very important aspect is that you must practice M mode. How do you practice M mode? You practice on 22 to 24 weeks normal pregnancies. One is that you try an M mode on a live scanning. Second is the use freeze, press P2, save a clip, and apply M mode on that. So you must practice at least 1 or 2 patients in a week, so that when you actually encounter an arrhythmia, you are prepared. And you should also go to all the sites for Doppler for arrhythmia assessment. And it's rightly said, once you are supposed to perform a CPR, you should have practiced CPR before that. You can't perform otherwise. So you must practice M mode before you encounter an arrhythmia requiring your expertise on M mode. And that's the M mode. You can see these are the atrial contractions which are not transmitted. They are independent of the ventricular contractions, and this is a case of complete heart block. But in this rhythm regular, you see one ectopic which is a ventricular ectopic, and it's not here on the atrium. Now this is another M mode, and atrium these are the atrial contractions, these are the ventricular contractions. And how do we use a ladder diagram? We use a ladder diagram. We try to connect atrial with the ventricular contraction. So this atrium is producing this ventricular contraction, and this is coming premature. Look at the distance between this and this. So this is premature atrial contraction. That means supraventricular ectopic or premature atrial contraction passes through and produces a ventricular contraction. Another atrial premature beat passing to the ventricle, and then this is a gap, and that's a normal beat. So by ladder diagram, you can actually make an assessment of the arrhythmia better than a visual way. The blocked bigeminy. Now many times if you have, what is bigeminy? Bigeminy is when the ectopics are coming in a sequential manner, one normal beat, ectopic, normal beat, ectopic, normal beat, ectopic. So that means it is called a bigeminy or atrial bigeminy, right? So sometimes what happens is that atrial bigeminy is blocked. The atrial ectopic is not conducted to the ventricles. It very commonly happens, and if it is not conducted to the ventricles, there would be no ventricular contraction. These are called blocked atrial ectopics coming in bigeminy. See the example, that's the P wave, normal, conducted to the ventricular wave. Done. Second is an ectopic. You see this excursion here on the atrium. This is an ectopic, but you don't see any ventricular wave down there. If there is no ventricular contraction, this means this got blocked, and the commonest places get blocked is an AV node. Same, another normal sinus conducted to the ventricle, and you have an ectopic which does not have any correlation in the ventricle. So these are called blocked atrial ectopics. Many times it does look like a 2:1 AV block. The decision of 2:1 AV block is very, very different than blocked atrial ectopics. Blocked atrial ectopics are self-limiting, do not require any treatment, while 2:1 AV block usually associated with the immune related heart blocks, and you need to start steroids immediately to prevent a congenital complete heart block to happen, because if the congenital complete heart block happens, then steroids are useless, they don't work. So this is very, very important to differentiate blocked atrial ectopics from 2:1 AV block. If I tell you the incidence, blocked atrial ectopics would be in 90% of the rhythms what you see, and only 10% would be 2:1 AV block. So blocked atrial ectopics, they tend to disappear over a period of time. So you need to differentiate. How do you differentiate? Because the ectopic by definition appears premature. If you get a premature contraction of the atrium, this interval between these two beats, normal and premature, is shorter than the distance between this premature beat and the normal beat. So if this is a variability in the duration of the PP contraction, that is an indicator of 2:1 AV block. That's an atrial fibrillation. You see the atrium is fibrillating, and ventricular rate in normal atrial fibrillation should be irregular. In this, the ventricular rate is regular. You see the M mode here. You see this fibrillatory waves or flutter waves, and the ventricular rate is absolutely regular. So that means they are both not associated with each other, could be a complete heart block associated with it. So M mode helps you to look at the ventricular and atrial contractions separately. Rare case, but now look at the atrial beat, and you recognize the atrial beats are happening at a certain rate which is faster than the ventricular rate. But ventricular are coming together, two beats, and a gap. And what is happening? Let's understand this. First we calculated the atrial rate, it was 420. Then we saw the ventricular rate by averaging 4 beats, it was 280. Okay, so now what is happening here is that this is a patient of an atrial flutter. If the rate is more than 400, it is atrial flutter and not SVT. So atrial rate more than 400 indicates atrial flutter, and you see these flutter waves here. One flutter wave goes and the ventricular contraction is there, and then it goes back. The second waves come because this is a circle. The atrial flutter is in circuitry motion, that's why the rate is very fast. The second flutter wave goes down, it's conducted, but the third flutter wave is not conducted. Again, one is conducted, two is conducted, and third one is not conducted. So this is a phenomena what we call as a 4 atrial beats. There are 3 atrial beats to 2 atrial beats. So there is a 3:2 AV block. 3 atrial beats lead to 2 ventricular beats is 3:2 AV block, which is very common in atrial flutter. Going to show you a very rare case. That is a case of a ventricular tachycardia. You look at this rhythm, the 2D clip, you see there is fast ventricular rate. Intermittently the ventricular rate becomes very fast, but notice carefully the atrial rate is slower than the ventricular rate. If the atrial rate during that episode of tachycardia, which is intermittent, is slower than the ventricular rate, if the ventricular rate is faster than the atrial rate, is ventricular tachycardia. If atrial rate is faster than the ventricular rate, it's atrial tachycardia. See the next clip, again intermittent fast ventricular rate, which indicates ventricular tachycardia. To prove our point, this video clip was saved with us, and we applied an anatomical M mode on this saved clip. Now we applied the anatomical M mode, and you see the ventricles are contracting irregularly. Okay, so that is how we know, and this cursor is on both the ventricles. Now we put an anatomical M mode on both atria and ventricle. Now this is a normal atria ventricle contraction, atrial contraction, ventricular contraction, atrial contraction, and ventricular contraction. Agreed? And this is where the ventricular tachycardia starts. You see, this is the ventricular contractions, but the atrial contraction remains the same. So that means this is the ventricular tachycardia, but atrial contractions are not affected. Faster rate here, slower atrial rate indicates ventricular tachycardia. Again, atrial rate is constant, ventricular rate is faster than the atrial rate, and this is an indication of a ventricular tachycardia. We know one condition which we call as torsade de pointes, and in this the ventricular tachycardia is polymorphic. It doesn't have a single shape, multiple shapes, and the name is given to twisting of the points. Occasionally ventricular ectopic beats are on one side of the baseline, and then they are on the, see, this ventricular tachycardia is on one side of the baseline, comes, and then it's on the other side of the baseline. Now it's positive, it was negative. So in the fetus, the classic triad of torsade de pointes. The classic triad is if you have a patient with atrial bradycardia or bradycardia, there should be episodes of bradycardia or AV block. Now in this ventricular tachycardia episode, the atrial rate was somewhere 80 to 86. So this was an atrial bradycardia. This is one. Number two, you have an irregular ventricular ectopic tachycardia. You know, this is not a regular tachycardia. Thirdly, the irregularity also is seen in the velocities of the outflow tract, the variable velocities on the outflow tract. Okay, that indicates irregularity of the ventricular tachycardia. And putting all these three features together, this qualifies for a fetal torsade de pointes. I would probably give you another short episode on M mode, and where I'll give you a demonstration on the machine how to perform an M mode. So I hope these videos should be useful to you. I would keep on posting difficult thing, trying to make it simple, and I would share you rare cases for some pattern recognitions. Thank you for watching this.